let's go ahead and get started. So welcome everyone to today's OneLab Network event. My name is Chelsea Parsons and I'm a consultant with Guidehouse supporting CDC's OneLab initiative. I have a couple notes about the webinar before we dive in today. If you're having any technical issues throughout, you are more than welcome to email our inbox at onelab@cdc.gov. That's onelab@cdc.gov. You'll see that pop up in the chat there. If you have any questions that are coming up with today's webinar technically, you can go ahead and reach out to that email address. However, if you have questions throughout the session related to the material that we're discussing today with the newborn screening system frameworks and quality assurance, you can post that into the Q&A function. So you'll see down in the bottom ribbon that we have a Q&A function. And in there, you can post questions to the presenter about the content. We'll also have closed captions available if you need them today. So please note that the link to those are going to be posted in the chat. If you would like to use closed captions today, please open up that link and keep it separate from the link we have to open up the Zoom. So if we can go ahead and get to the agenda. Today, we will start by discussing some new OneLab resources, and then we're going to go through introductions of our speaker today. We'll have about a 10-minute Q&A session after that presentation led by our speaker, and that's where we'll go through as many of those Q&A questions as we possibly can. If any questions arrive following the event, again, you're more than welcome to contact our email at onelab@cdc.gov. That's onelab@cdc.gov. If we don't get to your question today that you put in the Q&A function, we will do our very best to reply back to you via email, just as long as you don't submit it anonymously. Finally, today's session will end with a discussion of upcoming OneLab events. So let's go ahead to the next slide. So just wanted to note that for today's webinar, we will be leaving the chat feature open for your engagement. When utilizing the chat box, please be sure to keep in mind the appropriate rules of engagement. Feel free to use the chat to connect with others by reacting to what you're hearing, sharing experiences you might have, and asking questions to fellow participants. However, if you have a question about the content for the presenter, that's where you'll post in the Q&A. So Q&A, questions for the presenter and the content we're discussing today, chat box, engaging with your fellow peers on the call, adding in any stories or experiences you might have, things of that nature. Additionally, we ask that you please engage with respect and professionalism. Any inappropriate language, improper conduct, or any form of discrimination may result in removal from the webinar. Please ensure your comments are relevant to the topic, and if the moderator gives any direction regarding the chat behavior, please comply accordingly. Lastly, please notify moderators if you experience any technical difficulties or observe any disruptive behavior. All right, so now I'll turn it over to our OneLab Network lead, Alicia Branch, to share some of our new and relevant resources and introduce us to our speaker today. Alicia?
Thank you, Chelsea. Before the main presentation, I would like to share a CDC Laboratory Outreach Communications System, or LOCKSS message, and the release of a new OneLab training resource. On July 17th, a CDC LOCKSS message was sent announcing the publication of a new desk reference graphic, conjunctival swab specimen collection for detection of avian influenza A, H5 viruses. The infographic describes the procedures for collecting, storing, transporting from suspected infection and confirmed infectious patients for avian influenza A, H5 testing. You can view the graphic using the link in the chat. And if you have any questions about this graphic, please send them to locks@cdc.gov. Next slide, please. In our ongoing commitment to delivering high quality, accessible, and relevant training, we are thrilled to announce the release of our first mini lesson, Public Health Laboratories 101. Mini lessons are designed to provide a concise and engagement learning experience, making it easier to absorb key concepts quickly and efficiently. This mini lesson is informative, it's interactive, and it's easily accessible and available on OneLab Reach. You can find the link in the chat. Next slide, please. Now I'll read a PACE disclaimer followed by introducing today's speaker. CDC, our presenters, our planners, wish to disclose that we have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. And I'm excited to introduce our presenter for today, Dr. Carla Cuthbert, the Chief of the Newborn Screening and Molecular Biology Branch and the Division of Laboratory Sciences at CDC. Since December 2009, she has provided leadership and oversight to the Newborn Screening and Molecular Biology Branch. This is a branch comprising of several laboratories that support performance evaluation of domestic and international newborn screening programs as a proficiency testing provider and by creating and distributing other quality assurance reference materials. She is excited to share an overview of the newborn screening system and the critical role of quality assurance, technical assistance, and the success of newborn screening programs nationwide. Our presenter for today is Dr. Carla Cuthbert. Over to you, Carla.
Well, thank you for that kind introduction. It is a pleasure to always be able to speak about newborn screening. As chief of this branch, I am surrounded by wonderful scientists. As a member of the newborn screening community as a whole, I am always in awe about the passion of the scientists and the people that are involved in this big community. And really what I want to get across today is that it's not just a test. It is a wonderful system of very, very passionate, very driven individuals. And we really are working towards making things better. So again, today I'm going to be talking about the newborn screening system as a whole, laying the foundation of where we've been, because that gives us some sense of where we're going to be going. And then talk to you a bit about quality assessments and technical assistance in being able to nudge us towards a better outcomes and to making things better in the system as a whole. So thank you again for tuning into this One Lab Network event. And we're going to go into the next slide. Thank you. Next slide, please. Back to the outline. So the outline for today, we're going to separate the session into three parts. First, I'll start about talking about the history and the evolution of newborn screening. From there, we're going to discuss the newborn screening system and the multiple processes and partners that must come together to make this work. And from there, we will end with a discussion about the importance of quality assurance and technical assistance across the entire system. Next slide. So let's start with some history of newborn screening and a discussion of how the system continues to evolve. Next slide. To truly appreciate how newborn screening came to be, it's important to really start at the beginning. So for newborn screening and phenylketonuria, or PKU, this beginning really highlights the remarkable role of advocacy. If we look at the advent of newborn screening for PKU, we can go back to 1934, when a Norwegian mother fought to understand the cause of her children's developmental delay, leading to the discovery of PKU as a disease. Moving along to 1951, the treatment of PKU, which is the removal of phenylalanine from the diet. This was largely discovered due to the perseverance of a British mother with a child that had PKU. And from there, if we go across the pond into the 1950s, we see that the creation of two tests for the earlier diagnosis of PKU came about through a wet diaper ferric chloride test that came out of LA. And a short time later, there was the bacterial inhibition assay developed by Dr. Robert Guthrie out of Boston. And this would later form the basis of the first newborn screening test. Next slide. Because of Dr. Guthrie's own experience with the late diagnosis of PKU in his niece, he became very much an advocate himself, remarking on a number of occasions that this PKU test should be available to all children. And to make this happen, he worked with public health officials to mandate the screening rather than implement it as part of a medical system standard of care. Next slide. Around the same time as the advent of newborn screening for PKU, there was a general shift in public health to focus on chronic disease, as well as the desire to focus on prevention in developed countries. So in 1968, the World Health Organization, or WHO, commissioned a report from Wilson and Younger to provide a knowledge base on the principles and practice of screening. It is important to note that this report was not focused on newborn screening, but rather early detection through screening as a whole, including cancer and cardiovascular screening programs. And early on in this report, it's important to note that it made a very important point, that the idea of detecting a disease early, while it's admirable and it really seems simple, it is in fact very complicated when you're thinking about the successful implementation at an entire population level. Next slide. One highlight of the paper is known as the Wilson and Younger criteria, a set of 10 components that should be met in a population screening program. In the interest of time, I won't go through all of them, but I have highlighted a couple. The first are the first points are number 2 and number 3, which state that there should be an accepted treatment and availability of diagnosis of disorders, of diagnosis and treatment centers. Point number 5 is that we should, of course, have a suitable test. And finally, point number 7, that it's number 9, that the benefits of screening should outweigh the costs. You might notice that by looking at some of these, that if PKU were to be held to these criteria, it likely might not have met these guidelines at the time. Next slide. When considering the principles of screening, more diseases were added to newborn screening in subsequent years. At that time, however, the pace was largely limited by technology, as each of the diseases required development and implementation of its own assay. And as a result, between 1963 and the early 1990s, only 5 diseases were really routinely being screened for in the United States. Next slide. This slow pace of expansion quickly changed with the use of 2 significant technologies that have greatly facilitated increased expansion in newborn screening. The first was the growing use of tandem mass spectrometry in newborn screening, which allows for numerous analytes to be measured from a single punch of the dried blood spot specimen. And the consolidation of methods into this one test has given the rise to a new paradigm in screening called multiplexing, or many diseases in one assay model. Of course, as with many issues in screening, applying this technology can often be very far from simple. The technology essentially opened the floodgates and has given rise to discussions and differences in opinion as to what we might actually be calling screening when we're using this technology. Next slide. Secondly, building off of the work done in the late 1990s, showing the ability to recover a substantial amount of DNA from dried blood spots, we've also experienced a growth in molecular-based or DNA-based assays in newborn screening. Molecular applications have primarily been employed in newborn screening to improve screening performance, especially when only 4 biochemical biomarkers exist. But more recently, DNA-based testing has been used to detect disease-specific variants in severe combined immunodeficiency and spinal muscular atrophy. Next slide. So until relatively recently, then the expansion of newborn screening programs to include more and more diseases was largely limited by technological advancements. But our ability now to multiplex testing using tandem mass spectrometry, the incorporation of genomic and exomic sequencing, as that develops, it has moved a barrier that we previously had, and we now need to have a bit of a shift in our thinking. Testing technology may no longer be the limiting factor, and the limiting factor then becomes the availability of therapy. And so we must ask ourselves, just because we can test for which, should we? And if the answer to that question is yes, we should, then we need to figure out, we need to consider, how do we do that in a way that allows for continued innovation, that it needs to respect familial autonomy and privacy, and it doesn't exacerbate existing disparities in health outcomes amongst children. So lots of questions for us as we continue to move forward. Next slide. And ultimately, asking these questions, they've given rise to a number of initiatives that have been aimed at providing guidance at the federal level regarding which diseases truly meet screening criteria. And we want this in efforts to better harmonize screening practices across all of the states in the United States. The work created, the response to these questions have led to the creation of two important entities. The first was the creation in 2004 of the Federal Advisory Committee on Heritable Disorders in Newborns and Children, or the ACHDNC, which is overseen by the Health Resources and Services Administration, or HRSA. And secondly, the development of the creation of the federally recommended panel of disorders called the Recommended Uniform Screening Panel, or RUSP, which was a joint effort between HRSA and the American College of Medical Genetics in 2005. So using the ACHDNC and the RUSP mechanisms and approaches, there have since been 9 additional diseases that have been added to the RUSP since that time. Next slide. So let's talk a little more about the RUSP and its goal for harmonizing screening nationwide. The RUSP is made up of 2 distinct lists of diseases, the core conditions and the secondary conditions. The core conditions are those that are truly targeted by the assay. These conditions typically meet all of the screening criteria. And as of today, there are 38 core conditions on the RUSP, 36 of which are screened for by dried blood spot specimens, and 2 are point of care. It's worth mentioning that Krabbe disease was the most recent addition earlier in July. Secondary conditions are those that are incidentally picked up through screening for the diagnostic testing of these core conditions, and they may or may not meet all of the screening criteria, and currently there are about 26 secondary conditions. Next slide. So it is sometimes easy to think that because newborn screening primarily focuses on rare diseases, that its impact on the public's health is not as great. However, as this image shows, while individually the diseases on the newborn screening panels are rare, collectively they are quite common, impacting more than 1 in 500 babies born in the United States. I just want to point out that there is just a typo on the number of disorders, I believe on this slide and the previous slide. That should say 36. Next slide. So as growth in the number of diseases and the associated public health impact, these are not going away. In fact, this is growing owing to the technological ability to screen for more diseases and the increasing number of rare diseases with the associated treatment. So the predicted increases in the number of conditions and the ability to be able to identify more and more of these newborns is really only going to increase. Next slide. And understanding the evolution of this robust public health program and its ongoing and growing impact, in 2011, Newborn screening was named as one of the 10 greatest public health achievements in the 20th century. And this designation continues as newborn screening has remained a successful public health program in the 13 years since. Next slide. So now that we understand how newborn screening started and how it's been evolving, let's take some time to discuss the current newborn screening system. Next slide. While it is hard to sort of condense a complicated system like newborn screening into a simple slide, I have highlighted 6 key points that serve as sort of important hallmarks of newborn screening within the US. The first is that newborn screening programs are public health programs, meaning that they are administered at a state level and that they are overseen by state personnel. However, truly successful newborn screening programs rely on the coordinated effort of many numerous partners across a spectrum of sectors. Secondly, newborn screening programs in the US are also state-based. And while federal recommendations do exist on which diseases are deemed appropriate for population level screening, it really is up to each state to determine how to operate their own respective screening program and really which diseases they will screen for. So not surprisingly, this leads to considerable variations across newborn screening programs in the United States. The next point is that newborn screening programs in the US operate under a quasi-mandate whereby explicit consent is not obtained from the family. The default is for newborn screening to occur, and families may choose to refuse or opt out of newborn screening on their child's behalf. Finally, newborn screening programs are designed to only screen for those diseases that have effective pre-symptomatic treatment. And this is really one of a number of criteria that diseases must meet in order to be added onto newborn screening panels. Next slide. So when we think about the newborn screening system itself, we consider 6 distinct but related parts. And this graphic is really meant to show the connectivity between them. We, of course, have screening itself, which occurs within laboratories and have a number of components to it. This is followed by notification and follow-up of those results. This leads to a diagnosis, a timely intervention and management of the affected newborn. And underscoring these 4 parts are 2 components that span the entire system: education and evaluation and quality assurance. Next slide. Another important consideration of the newborn screening system are the legal foundations of newborn screening. As mentioned a couple of slides ago, newborn screening operates essentially under a public health mandate, though parents can opt out or refuse on behalf of their child. 2 primary frameworks we utilize are shown here, and it includes the 10th Amendment, which indicates that states have the power to regulate the receipt of medical care to protect the public's health, and a common law doctrine called parens patriae, and that permits the state to make decisions for the health and the well-being of its citizens who cannot speak on their own behalf. And in the context of newborn screening, this of course means the newborns. Next slide. This schematic illustrates that newborn screening, even with the use of molecular testing, is still really only a risk assessment. On the left, we start with a seemingly healthy population of newborns, and using a filter paper matrix and examining a number of biochemical and molecular analytes or biomarkers relevant to disease, we separate out those that are at higher risk for having one of the screen disorders, shown in orange, from those who are at lower risk of being affected and who pass through the screen essentially, and these are shown in green. On the top of the middle panel, when we look at that part of the slide, because this is a screening program, any child that is identified as high risk needs to go on to have orthogonal diagnostic testing to determine if the screening result was actually a true positive result. And at the top right panel, it is a true positive, of course, if the child is indeed affected with a target disease as a result of this testing, and classified as a false positive if the child is found not to have the target disease based on orthogonal diagnostic testing. Looking at the bottom center and bottom right of the panel, we really need to remember that in screening, we really cannot forget about those who are deemed low risk by this initial process. While the vast majority will indeed be unaffected or have true negative results, there does exist the real possibility that an affected child is missed by the screen and is thus considered a false negative result. Next slide. The next 3 slides dive a little into the newborn screening dry blood spot screening processes in a little more detail to illustrate various parts of the system. Looking at pre-analytical parts of the process, families should be provided education about screening before the sample is collected. Blood samples should be collected between 24 and 48 hours of birth. These samples need to be dried for at least 3 hours. Specimens should be then sent to the newborn screening program within 24 hours of collection. Next slide. Once samples are received, we can look at the components of the analytical process. Specimens are accessioned, demographic information is collected. Depending on the test, blood from small punches can be extracted into 96-well plates. The blood that's extracted or the punches, these are analyzed either on biochemical or molecular testing platforms, and the results are reviewed, assessed, and this information, the interpretation, is then sent on to the follow-up step. Next slide. Owing to the critical nature and the time-sensitive nature of many of the diseases that are being screened for, results need to be made available very quickly. Results need to be available by day 7 after birth, and in some cases a little earlier. Positive results are called out, normal results are submitted to the provider, and families should be made be informed as soon as possible. Next slide. So while we've been focusing on the newborn screening process and the last previous slides, it is also really important to be able to put this into the context of a journey that would be experienced by the families with a rare genetic disorder. And so we have this slide that shows very similar workflow, but really from the point of view of a family. So newborn screening really is truly one part of a much larger system, and a larger system that needs to be in place to ensure that babies with these diseases can truly be identified, be put into appropriate treatments so that they can reach their full potential. Next slide. And in the previous slides, I highlighted that newborn screening is a system involving and impacting numerous partners who must all work together to keep the family experience and the patient and health outcomes at the center. So while we often discuss some of the obvious partners, public health labs, clinicians, researchers, advocates, this slide really centers us and reminds us that there are so many more partners at all different levels who need to be involved for a newborn screening program to truly be successful in meeting its vision and mission. Next slide. The system relies heavily on a number of national organizations and federal agencies to help ensure its success and ongoing quality. We've listed a few. It's not an exhaustive list, and it's not even an exhaustive list of what these entities actually do. The College of American Pathologists provides accreditation. Centers for Disease Control and Prevention administers a proficiency testing program, provides technical assistance and training and funding, and other data analytic resources to assist state programs. The Centers for Medicare and Medicaid Services regulates clinical laboratory testing through the Clinical Laboratory Improvement Amendments, or CLIA. The Food and Drug Administration provides oversight of drug development and laboratory developed tests. The Health Resources and Services Administration, or HRSA, provides funding support and oversees the Advisory Committee on Heritable Disorders in Newborns and Children. And the National Institutes of Health provides funding for newborn screening related research and pilot studies. So again, just to bear in mind that as federal entities, we do have regular meetings where we get together and discuss from a federal point of view issues that would be impacting newborn screening. So again, this indicates various different activities that reflect the different missions of these agencies. But we do come together to have discussions to ensure that we can leverage what the other is doing specifically in the arena of newborn screening. Next slide. So the last point I wanted to highlight as we discussed the newborn screening system really goes back to the idea that newborn screening in the United States is state-based. And as I mentioned previously, this leads to wide variation in practices. And these variations can include differences in which disorders are added, testing and follow-up practices, as well as funding and infrastructure. So this is well known, and when state programs get together, they're very much aware of differences. But I do, in speaking to these programs, even though they come from very different situations, they really do lean into each other to be able to gain experiences that can be shared across their respective programs. Next slide. There are a number of resources that are available to programs that can assist them in understanding, to assist in understanding the system. And we wanted to be able to highlight some of these things as well. The next slide, are some of the activities that we have in our own program at the CDC under the Newborn Screening and Molecular Biology branch. We're engaged in newborn screening test development, where we develop new tests for new biomarkers or anticipated conditions. And also we spend some time looking at some tests that really require some improvement and enhancement. We provide technical expertise and technology transfer to be able to pass information on to the states through consultation, one-on-one visits, site visits, training opportunities, and so on. And we create reference materials for both quality control and PT and other resources as it falls under our purview. Next slide. Programs should also take a look at the Clinical and Laboratory Standards Institute, which is CLSI. CLSI has a wonderful resource that has a large suite of newborn screening guidelines and standards. So you can see there are reports and standards that cover various disease-specific issues, and they address things like sample collection, testing methods, result interpretation, and follow-up procedures that really cover the gamut of a lot of the issues that the newborn screeners would need to address. So a very valuable resource, and it really can help the programs to ensure high quality and consistent and reliable testing processes. Next slide. And programs really rely very heavily on this resource. It's the Newborn Screening Technical Assistance and Evaluation Program, or New Steps. And this is overseen by the Association of Public Health Laboratories, and it provides technical assistance, training, resources for continuous quality improvement. Truly a wonderful site for state programs that cover, again, a spectrum of different kinds of activities, and is a wonderful resource for state programs. Next slide. So for the last part of my talk, I wanted to highlight the importance of quality assurance and technical assistance across the newborn screening system. Next slide. And to start, it is important that we're really using the same language and understand what QA means within the context of newborn screening. It's not entirely just focused on laboratory aspects. Quality assurance in this context is the monitoring and evaluation of various aspects of the system to ensure that standards of quality are being met. And for newborn screening QA, it's a dynamic process of defining and measuring the quality of performance of the entire screening process. And as such, both internal and external quality assurance activities are needed for continuous quality improvement. Next slide. While many may think of quality assurance as being separate or unrelated to the patient, these activities put together truly are key to ensuring the best health outcomes for patients and families. Quality assurance in newborn screening includes, but is not necessarily limited to, these 6 components that are described here. Good practice, understanding and implementing best practices within the laboratory and follow-up systems. Standards, using good standard practices and policies for newborn screening, for laboratory testing and follow-up. Active monitoring, tracking key performance indicators that identify gaps in quality improvement opportunities. Site visits, having these external assessments to review your processes is really beneficial. Reports, be actively tracking various performance activities to make sure that you are making progress with key activities. And of course, training, improving capability within your staff to make sure that they're keeping up to date with technical changes. Next slide. So if we remember back to the slides that show the pre-analytical, the analytical, the post-analytical processes, we can also think of quality assurance using this same framework. So in the pre-analytical space, quality assurance is needed to manage and assess various critical steps in this process. Checking the specimen integrity, timing of the sample collection and receipt, and sample handling as it gets transported to the laboratory, verifying kits and reagent lots to make sure that they're not expired, checking instrument performance to make sure that it performs according to specs, ensuring that you have preventive maintenance schedules that you adhere to. Those are important as part of the pre-analytical quality assurance steps. Next slide. In the analytical space, quality assurance efforts include monitoring calibrators and standards and controls, verifying biomarker measurement trends to make sure that your measurements are, that you're tracking any sorts of trends that you may be seeing, refining cutoffs, maintaining staff competency and proficiency testing performance of your testing process and system. Next slide. And then finally, in the post-analytical space, quality assurance can include timely reporting of results, assessing population-based performance metrics, and making sure that you keep on top of that, seeing how you compare with other programs, following up on unsatisfactory samples, and providing feedback that can lead to various kinds of quality improvement initiatives. So again, quality improvement is something that you look at throughout the entire process. And the next slide. It's the last slide, I believe. To end, I really also just wanted to talk about the role of technical assistance along the newborn screening system itself. And really just to indicate that programs need to be ready to provide technical assistance across the entire system. It's not just a laboratory function where we only focus on what the laboratories are doing. As the complexity of testing and the number of diseases screened for increase, there is going to be an increasing need for technical assistance across the spectrum. And this includes providing assistance to birthing centers and midwives and giving them information as needed. Public health staff, of course, as they carry out their important work. Primary care providers and other specialists. Examples of these are like act sheets that have been supplied to be able to help them understand how to manage these newborns and so on. So information needs to be relayed so that there is consistency and so that there is a really good understanding of how to manage the newborns identified throughout the system. And so that's largely it for the presentation of the last slide. Next slide. I thank you again so very much for your attention, and I just want to note that this event is just the first of many newborn screening webinars that we hope to create, and it really is meant to sort of lay the foundation for numerous other training opportunities for newborn screening that will be forthcoming using this one lab mechanism for training. So with that being said, thank you everyone, and I'm happy to hear any questions.
Thank you. We'll take a few minutes to answer as many questions as possible. If we do not answer your question today, we'll do our best to respond via email. And if you have questions after today, please email the OneLab inbox at onelab@cdc.gov. Let's see what we have. So the first question is diabetes disease a part of the newborn screening?
Diabetes disease is not part of the newborn screening process. It is not.
The next one is, are the laboratory developed tests acceptable for newborn screening?
Are laboratory developed tests acceptable? Yes, you will actually find that in practice that many of the tests that the states use are laboratory developed tests. Just because there may be a very quick turnaround time and a mandate by that state to bring on the test very quickly. To be able to get various kits from certain vendors, that can take quite some time, and some states may not have that length of time. And so there's just an active amount of work within the state programs to be able to develop testing on, especially on tandem mass spectrometry platforms, to be able to identify the relevant biomarkers of interest. So yes.
They had a follow-up question, but I'll send that to you after, because it may take quite a bit of time to explain that one.
Sure.
I'll just throw some other questions. How can programs request the quality assurance and technical assistance from your team?
From our team in particular at CDC, one of the best way to actually do that is by email. I believe in one of, we can let you have this. It's the NSQAP dmt@cdc.gov. That's a mailbox that will get any sort of questions directed to us so that we can respond as needed.
So this is a good one. how do you see newborn screening testing in the near future as it's seeing a transition in technologies?
Yes, we do gather together as a community with a bit of a crystal ball, trying to anticipate where things are going to go. And I'm being truthful to a large extent there. Where we see newborn screening moving in terms of testing, we do believe that tandem mass spectrometry will continue to play a very robust role. Tandem mass spectrometry looks at biochemical markers for metabolic diseases, are a really good way of being able to detect newborns that are under stress and that have what's called decompensated, and that are showing key biomarkers, and it's very quick. And it does take a knowledge of the system, the biological system, and the biomarkers of interest. So that I believe will continue to happen, and I think that as we move forward, perhaps metabolomics, as the mass specs become better, I anticipate being able to identify more and more biomarkers under a single biochemical platform is going to be very important. Another thing, another platform, and we spoke about these two big platforms, is with respect to newborn sequencing. And so the bringing in bringing in DNA-based testing for spinal muscular atrophy and severe combined immunodeficiency really did transform newborn screening programs to set up their laboratory workflows to accommodate DNA-based testing. The big future, with a lot of question marks, is with sequencing and whether or not we will go the route of genome or exome sequencing to look at larger number of biomarkers. There's a lot of discussion about that because most programs are just not equipped right now to be able to go that route. There are a lot of questions involved in how you would interpret that information, and it does require a lot of infrastructure for data analytics. So there's a lot of excitement if you're a scientist just looking at it from that point of view, but strategically, there are a lot of other bits of infrastructure that need to be in place to be able to mark out what that future is going to look like. Very long answer, but clearly this is something that rests very heavily on our hearts as we look at the future of newborn screening. But
Yeah,
great question.
And I'll add that they did mention about next gen sequencing. So
yeah, yes, we're all thinking about it. I think that an initial step is that we need to bring in next gen sequencing as a as perhaps a second tier test, get used to what's needed and the workflow that is needed, because the states are not even there, right?
Yeah,
And so
right.
as that moves on, I think then we can then ask the questions of, what happens if we look at many more genes at one time, and what does it mean? We need lots more genetic counselors before we can even make a move in that direction, or we'll just overwhelm the system. But fantastic questions. But it's our future. It is our future. So
I'll go back to the question. Do you know the percentage of requested repeat testing are actually followed through with collection?
That really would be a bit state dependent. I couldn't give you those results right now. I couldn't give you those results. I think if you're interested in something like that, perhaps you can speak directly to one of your states to reach out to get that kind of information.
This is a good one. Are newborn screening collections arriving at the testing center after 24 hours acceptable?
So each state will have their own respective policies on how they will handle samples that may not specifically meet their criteria. Okay, so again, I know that we had that hard line, it must be there after by 24 hours. There are some situations in which couriers may take a little longer. The states will defer to their policies. I think that one of the things that we may also think about is that, you know, as if part of their policy is to have a request for a new sample, some of them may test to see what is there and just handle that very specifically, but you certainly would have to consult their policy. One thing we don't want to do is miss a child that may be going into crisis. So each program will have a special way of handling that.
Okay, that's all the time we have for questions. We will send you the other questions that are in our Q&A box for you all can answer them offline. And I want to say thanks again, Dr. Cuthbert. We look forward to actually bringing you on again in the near future to present at another OneLab event.
Sounds great.
Thank you. We are offering one PACE credit for today's webinar. PACE certificates are immediately available on OneLab Reach in your My Learner hub for easy access. To receive your PACE credit for participating in today's session, you have to log into your OneLab Reach account, visit the link in the chat, and use the passcode to complete the evaluation within 2 weeks. You must be logged on, again, you must be logged onto your account to access the evaluation as well. You will also receive an email containing the instructions if you missed the link and the passcode in the chat. Next slide, please. I'm thrilled to announce several exciting upcoming OneLab events. Don't miss the final opportunity to attend a OneLab exclusive Elevate Your Expertise event. This is a 1-hour virtual learning session. Revolutionize your laboratory SME delivered presentations. During this session, you will discover some proven strategies to captivate your audience and leave a lasting impression, all while enhancing engagement and retention. That's not all. You'll also receive a certificate of completion to share on your LinkedIn profile, showcasing your newfound skills and highlighting your accomplishments to your professional connections. The final session will be held on August the 1st. You can register now using the link in the chat. Next slide, please. Lab Network event, ISO 35001 2019, Biorisk Management of Laboratories, will be held on Monday, August the 5th from 1 to 2 p.m. Eastern Standard Time. The registration link has been posted in the chat. Next slide. Attention testing professionals, join the upcoming OneLab Test Open Forum event on August 13th at 12 Eastern Standard Time to discuss training and education needs for testers who work in non-laboratory sites. Registration now is available in the chat. And please share this news about this event with your colleagues, especially those who perform point of care testing outside of a traditional laboratory. Next slide. As a reminder, the slides and audio recording of this event will be posted to our website within 2 weeks from today. And lastly, I encourage you to utilize our OneLab inbox to share your training needs and feedback on OneLab with us. We use your input to select event topics and better understand the community needs. The OneLab email email address has been posted in the chat for easy access. And again, thank you for participating and have a great rest of your day.